So I'm Deepak Gupta. I'm one of the neurologists here at the Binter Center, and this memorial lecture we are doing today. This is the second one. We had the inaugural one last April. As you can probably figure out from the last name, it's related to me. So it's for my dad, who lived with Parkinson's uh, for 13 years. And actually, before I say anything further, I want to really express my gratitude to the Binter Center at the UVM Medical Center and the Department of Neurological Science at the University of Vermont for hosting this memorial lecture in memory of my father. And we organize it in place of our grand rounds. So, in addition to you guys being here, our patients and their family members, it's also being attended by our department faculty members and staff and employees and other people outside of the institution through Zoom. So, just want to briefly talk about my dad, and then we will transition to listening the wonderful talk we have planned from our visiting speaker. So, my dad, his name was Ashok Gupta. He passed away in April 2021, as I said earlier, at the age of 64. Um, and many people have asked me in the past as to what's the motivation for me to organize this memorial lecture. One is obvious, it's in his memory, but one is actually special to me. And it's kind of a not so good special, but you make good out of not so good things, I suppose. So I'm an immigrant to the United States. I came in 2012 to start my residency, and he could never visit me in States. For some years there were some visa issues, then he got visa, and he was not doing well. Parkinson's kicking in more. And then he was scheduled to come to see me in May 2021. Um, all tickets booked, he and my mom. And then he got sick and he unfortunately passed away. So I just take this lecture as him visiting me every year. So that's how I take it. And the only other thing I say, well, he visits me every day when I see patients. Like my patient said one day, he visits you in every patient. Just wanted to lay that context out and just briefly about him so you know a little bit about him more than what you read on the handout. He was born in India in a rural place. It's a village called Kikra, just sort of north of New Delhi, about 20 kilometers from New Delhi. Um, he was son of, Mrs. Ramvati Devi and Mr. Suresh Gupta, my grandparents, and one of the four siblings. He was husband of my mom, Miss Sudha Gupta, and he was father of three of us, my siblings and me, elder son, my elder brother Vipin, myself, and my elder sister Anjali. And then our uh, my wife Rashmi and my in-laws and six wonderful grandkids. He didn't get to see Kavya, who's the youngest of all, because Kavya was born in December 2020. He didn't get to see her in person. Um, so he achieved quite a bit in his life, despite being born in a rural place in a family where no one had gone to college or high school. He did full education, all the way to masters. Actually, two bachelors he did in economics and education and master's degree, and then he was a religious and family man. He practiced as the Hindu through his life. He was a school teacher for several years, I think 30 plus years. He taught economics and English to high school kids, and he was a Parkinson's patient for 13 years, and I think he was a life lived for 64 years, despite it being somewhat short than what he could have more lived, but it was worth it. So just wanted to say a few words about him, and certainly you have more information about him through the handout. So I'm not going to bore you with all details. At this point, I think I would like to transition into our visiting speaker about him and the talk. So Dr. Michael Schwarzschild, it's an honor for us to have him as our second memorial lecture speaker. He comes to visit us from Boston, and not too far from here. He's a professor of neurology at Harvard Medical School and a clinical neurologist. But I do want to take a few moments for you to learn more about him from Dr. Boyd, who is our director at the Binter Center. So, Dr. Boyd, if you don't mind coming for maybe a couple of minutes and share your perspective. You have known Dr. Schwarzschild more than me. Just talk briefly about him.
Certainly, and I want to. So I just want to reiterate what an honor it is to commemorate and think about Dr. Gupta's father every year, and I think it's really kind of a special day for all of us each year to think about that. I'm going to try not to take away a lot of time because I want to give that time to Dr. Schwarzschild. We're really, yes. Was that my wife? So I wanted to give that time to Dr. Schwarzschild, I was saying, but at the same time, to thank him before he gives his talk for coming up and spending some time with us here in Burlington. Among our Parkinson's research community, he needs absolutely no introduction and is really well known for his pivotal work. Dr. Schwarzschild has been down at Mass General and the Harvard Medical School since the mid-90s now, and has been the director of the molecular neurobiology research division there. He is a movement disorders neurologist and Parkinson's specialist. He has done some of the pivotal work in the interactions of several purines. Ones that would be familiar to you would be caffeine, other ones adenosine and urate, which have been essential in terms of his work of identifying potential contributors to and potential preventers of the progression and development of Parkinson's disease. I'm certain he'll speak a little bit about those today. We were fortunate to participate in one of his clinical trials that investigated the potential impact of manipulating the purines and trying to elevate uric acid levels in the blood. And unfortunately, that was not a positive study, but it was a privilege to be part of his large trial. So without further ado, I'd love to introduce Dr. Schwarzschild, have him come up and speak with us.
With no further ado, we'll hand it over to Dr. Schwarzschild.
Thank you. Thank you, Dr. Gupta. Dr. Boyd, it's a great pleasure to join in the honor of this lecture for your dad. I have no conflicts for the contents of the talk that I'll give, which I should be able to advance this way. Left click. Okay. And then, yeah, that's good. Thanks. I'll be talking on prevention of Parkinson's. I also want to say, particularly with everyone coming out here and having a vested interest in Parkinson's, just off the top here, there's a lot of convergence about prospects of moving towards preventing the disease, some of it born out of some of the challenges of trying to slow down the disease when it's manifest, which might lead one to think, oh, okay, great. Slowing down the disease didn't work. Now we're giving up on folks with Parkinson's. We're going to try to prevent it. Not at all. On the contrary, even in those studies that are still ongoing, that I'll review a bit, trying to slow down Parkinson's disease. Any of those who are involved, I've actually had the pleasure of meeting someone from 20 years ago in one of the studies we did just at lunch. Any of those involved know that we've typically done those studies in people who have just been diagnosed with the disease, on this idea that we want to go as early as possible. And the idea being that if we can actually get traction with something that slows down the disease, then we'll be able to apply it to folks who already have the disease. And so that rationale still is in place as we now have the opportunity, for reasons I'll highlight, to look even earlier to try to slow down the disease. So, and now the buttons. Sorry, I'm glad you're nearby, Dr. Gupta. So, oh, maybe it's switched. Ah, okay. It's going back and forth. Thank you. Got it. Thank you. So, and just one other point about in the memory of Mr. Gupta that was already mentioned, that is a theme that goes through all that we're learning in Parkinson's disease, and what we hope to learn is that it's learning from those who are our educators. And just like beyond being a family man and Dr. Gupta's dad, in this tradition of teaching, I also wanted to highlight, actually with a niece, Stephanie here of Dr. Fahn, the inaugural speaker in this lecture, the role that those who have led the way in research are critical to the field. Also want to point out here that although I have little feathered edges around Dr. Fahn's image, he's still with us and gave a great lecture here just last year. And Dr. Fahn also wanted to shout out in particular because of his many contributions to Parkinson's clinical research. He also started an organization that was already mentioned, and I'll highlight further the Parkinson Study Group. He co-founded it with Dr. Ira Schulson, and that has been part of a community that has been leading studies trying to affect the course of the disease. And then for a little matriarchal balance, since we all appreciate our parents, for me, at Mass General, where I'm in neurology, Anne Young has been, until she recently retired, the chair of the department and also a pioneer herself on the science end of Parkinson's disease. So I mentioned the Parkinson Study Group, this collection of movement disorders neurologists across North America that have been doing trials for some, I guess, let's see, by this, some 35 years or so. This is Ira, who started it with the organization with Stan when they were at Rochester. I was just reminded that Bob Hamill was also in the Rochester group there, although I tried to pick him out from that picture, and he wasn't in that one. But that was when the group started off with a study called DataTop to try to slow down the disease. So we'll review the studies in general. This is the last sort of memento slide from Dr. Fahn, who early in my career, like many other teachers, was instrumental in encouraging folks to pursue their observations and insights to propose trials and other investigations. That's been an honor for me to be pursuing here with this organization. With my, for the last 11 years, Hubert Fernandez has been leading it with me. This was our last get together where I think with University of Vermont being such a prominent site, has been regularly participating in multiple studies. And I think Dr. Gupta and Dr. Duhl were both at the meeting last year. So this is what I'd like to cover. I'd like to explain why we are now thinking for the first time of conducting trials to slow down, to prevent Parkinson's disease. And I'll try to give you a little bit of the rationale and really what's changed in recent years that has made this possible to actually design these trials and figure out the elements, the pieces that have to be put together of who gets into these studies. And there probably we've had the most progress in the last couple decades, but also what to measure before the disease is what we call Parkinson's disease. And even what, if there's time, I'll go through a couple examples of considerations for things to test. So first, the why, and then I'll go through these other elements. And ultimately, I'll just highlight that this is a very communal activity with participants and all the contributing stakeholders in trying to help with disease. So the principle is kind of obvious. You know, why do you want to prevent something why do you want to do that instead of having to endure it? It spares a lot of burden. I've actually, as anyone might, thought of this age-old expression, an ounce of prevention is worth a pound of cure, which I had looked up and realized that that's a Ben Franklin quote, and actually went to the primary reference in 1735. And I'll mention how that was metaphorically instructive, or could be, as after I kind of define prevention. So it's worth just taking a moment to talk about prevention. What are we talking about? You know, you can distill it in medical terms, as NIH does, to an action taken to decrease the chance of getting a disease or condition. But then you get into another question, which is, what is a disease? When is it a disease? When is it a condition? And as you'll see, That's a moving, that's suddenly a very active question in a good way, because we're now thinking about going earlier. So when does the disease start? And I'll tell you about some recent progress there. So again, just what is prevention in a medical context? What we usually think of trying to modify the disease, arguably, is prevention. We're trying, in people with Parkinson's, historically, when we do clinical trials, we try to prevent progression to the next stage of the disease. And that's called tertiary prevention, as the number implies. It's a little bit downstream, and we actually don't really think of it as prevention, but that's sort of on a spectrum of here, sort of med school level discussion of the stages of prevention. Earlier, of course, is before a diagnosis is made clinically, and we'll get into what you need to do to try to prevent earlier, and when the disease is in process. And even before the disease is in process, there are ways to try to prevent the risks for the disease. And I won't go through a lot of metaphors, or actually not metaphors, but examples from medicine. Particularly, actually, I was going to go back to that primary text in 1735 in Philadelphia, when Ben Franklin said that, and he said it in the context of an essay called "On Protection of Towns from Fire." And looking it up, I could see that he actually goes on, and from a New Englander's perspective. Okay, thanks. From a New Englander's perspective, that it's kind of flattering, because Ben Franklin in Philadelphia was actually coveting the Boston Fire Department's equipment that they had developed to deal with fires, which was mostly tertiary prevention, which was ladders and fire trucks and the like. But he also went on at some length in this essay to talk about the trying to prevent fires earlier. And he noted that people would carry around shovels and with hot coals to maybe put in their bed warmers, or to move from another fireplace, and they would drop the coals, and that could lead to a cinder overnight lighting the place up. But he spent the most time talking about even earlier prevention, which was analogous to primary prevention here, before there was even any fire in the fireplace, lamenting that people would leave their chimneys unswept. And he made a passionate case for trying to prevent the disease, if you will, by these preventative therapies. And to the extent that he described aggregations in the fireplace that prevented the function of the fire, it's actually quite analogous to what Dr. Duell was so very nicely amongst several background points laying out about the gumming up and aggregation and blockages, perhaps from these synuclein aggregates, classically Lewy bodies, as depicted here. So the principle is pretty straightforward. It's good to prevent if you can, before things get out of hand. So there's some precedent too in terms of motivation. Personally, for me, I already alluded to, but for the whole field to start thinking about prevention. Now that, as I'll end with, the prospects, or I'll focus on most of the prospects are coming into place for actually doing it. The things we've been trying so far haven't worked out great. That's the precedent within Parkinson's of trying to slow down the disease after it's been diagnosed. And as I'll highlight, there's also some excellent precedents that are encouraging from outside of Parkinson, other neurodegenerative diseases, where prevention trials have already begun, and we have lessons to be learned from that. So in terms of some of the harshness of where we are with Parkinson's so far, it's as relatively graphically depicted by a colleague's graveyard analogy here to the many things that have been hopeful for slowing down the disease in manifest patients that have gone through phase 2 or phase 3 trials that are represented by their tombstones here. And most recently, there was a study that just reported out of Europe on an iron chelating agent that was fully negative. And then a couple that we did in the Parkinson study group, including the study that was mentioned, the urate elevating study, was clearly negative. And seeing that, as I'll show, there's still plenty of positive things to pursue, but it does make you look where at other ways to get at the disease. If there's better methods, better trial designs going earlier, as we'll focus on in prevention. And so I thought I'd just take a moment, especially with the contribution of a number of patients at the University of Vermont, working with Dr. Boyd and Emily Houston, their coordinator here over the years, how we got into it and how clearly and what we learned from it. So it's a bit of a theme. So, and we, our colleagues, Dr. Alberto Escurio at the Harvard School of Public Health, and I have gotten to team up over a number of years to try to understand epidemiological clues that his group has identified, and many others that have been linked not only to the not only the genetics clearly setting the stage, but associations of increased risk, particularly decreased risk or inverse risk factors that are telling us something about the disease, even though from epidemiological studies it's hard to demonstrate causality, nevertheless giving us hypotheses to pursue, some including the urate one, which I'll just kind of briefly highlight how we pursued that after the epidemiological evidence was so compelling, not only in the healthy population of people having higher levels of urate in their blood, being less likely to get the disease, but finding through collaborations with the Parkinson study group, and even people in the room who were in some of the studies where their blood was checked during the study where they tried a different drug to see if it slowed down the disease that didn't, but their blood could then be checked to see whether it related to how they progressed over the disease, and it did. So there was a convergence of epidemiology of risk factor evidence with higher levels of urate being associated with not getting the disease as much, and with people who have higher levels with the disease not progressing as quickly. And that also, as is a good rationale, that motif met up with further convergence from biological evidence, laboratory data, taking these targets into the lab, our best models, which are limited at best, but still useful, and finding that urate, in this case, was also a protectant in models of the disease. So all those things came together and prompted us to pursue a clinical path, which in this case was not commercially viable as urate, and what we could elevate urate with. A precursor called inosine it doesn't have commercial property rights of sorts. So we were able, with the investment of the community and foundations like the Michael J. Fox Foundation, and then the NIH, to do a series of systematic studies that ultimately led to the study that was conducted also here at the University of Vermont, which was a full, with supportive data all the way up, full phase 3 trial at 60 sites across the country. And what we did is use that precursor to elevate levels of urate. This just shows that because people were following the protocol, we actually, better than prior studies, for the most part, we actually knew that we were engaging our target. Like the people in the group that got the active medication, their blood levels over the 2 years of the study, you can see in the black line, increased and stayed increased. So, so we were able to elevate levels of urate. We actually were able to elevate it in the levels of their spinal fluid as well for volunteers who provided that, as opposed to the placebo patients who stayed low. So we knew we were engaging the target, if you will, from there. And then this, just to cut to the chase here, this is a scale on the left-hand axis. Again, over the y-axis, sorry, the x-axis is the time over the 2 years, 24 months of the study. And this scale is a measure of Parkinson's disability. And as you can see, as you know, it's something that increases over time. And the orange bar being those folks in this study who were randomized to receive the urate elevating treatment, which worked to elevate urate, but it did not work to slow down the disease. Also by another measure, to look at, in this case, as I already mentioned, the participants that when enrolled were so early in the disease at the time, as early as we can enroll them, and call it Parkinson's or something like Parkinson's, they were enrolled as so-called de novo participants. So they were within a year, more or less, of having been diagnosed, and they hadn't yet gone on dopaminergic symptomatic therapy, which, while insufficient to be sure, changes the response on those scales, because one gets some symptomatic improvement. So just looking to see over the course of the 2 years who got progressed enough so that they needed to go on dopaminergic therapy. As expected, that over an ethical 2-year study with de novo Parkinsonian patients, unfortunately, over half will not be able to hold off dopaminergic therapy, and so people increased. And whether they were in the placebo group or the active group, it made no difference. And then lastly, a bit also just sort of a testimonial to the rigor with which we were able to do this randomized study. We were able, and a testament to the participants as well, who not only gave their blood and urine, but their spinal fluid in some of those cases, but they also underwent brain scans that measured dopamine markers in the brain, which I'll show you in a second, more anatomically. But you can that marker for the dopamine brain cells, which that continues to decrease over the years after diagnosis, and over the almost 2 years of the measurements, on average, from their baseline, people did lose more dopamine neurons, presumably because they lost signal from this marker. And again, there was no difference. So we had a very clearly null response here, despite all the good background and convergence that made it a good hypothesis to test, and one that we tested well. So that might lead one. So we just added to this tally to the graveyard, so this is the discouraging part, and that might lead one to conjure some definition of insanity. Why do we keep doing the same thing over and over again and expecting the same results? But I would argue strongly, if you look at how we've done these studies, that by no means are we doing the same thing over again compared to that DataTop study where the PSG members had emblazoned on their T-shirts at 1985 data study. This study that we've done here, and many others that have gone on recently and are being planned, are being done with much greater potential for, and I won't go through exactly how we design the studies to be better, but finding out how to do better studies makes it more hopeful. And I'll also just point out too that even though, because there's a cradle side of this, and while it's a steady transfer, it seems historically, as I said, I think the studies that have been doing more and more recently are better shots on goal, if you will. And there's a whole new class of studies being done in Parkinson's patients, typically just when they're diagnosed, particularly focusing on the genetic clues of the disease that are terra firma for what's going on with Parkinson's disease. I won't go through them in particular, although I know that there are a couple of the studies ongoing here at the University of Vermont to target synuclein, for example, that are encouraging. So I took a little bit of the frown off there just because there's still plenty with people with Parkinson's where we are designing studies that are increasingly hopeful. But I also wanted to turn to what lessons that we're seeing from other neurodegenerative diseases and other diseases even more broadly, where prevention, there's a rationale to go earlier that is now more and more possible to do. And that this is just a ubiquitous concept that if the horse is out of the barn to some extent, it's hard to pull it back in. So going earlier, for all the reasons we just mentioned, is worthy of pursuing. And this is actually from I just learned about it a few days ago because we're so siloed here outside of Parkinson's and neurology. There apparently was a fairly big breakthrough, and the first preventative therapy for diabetes was just approved a few months back. And interestingly, as we'll come back to, part of the success of that approach was in having a rigorous way of defining and staging the disease that is in good part what's changing now to make prevention more of a tenable notion. So this is just looking at some of our sister challenges here: neurodegenerative disease, Alzheimer's disease, ADHD, is Huntington's disease. We are PD. And that the approach that's been taken, sort of piecing together how you do a prevention trial, can be simplified into the who to enroll, who's at high risk for the condition, what to test, and how to measure what you're preventing. And I'll just note that it's different for the different diseases. Huntington's disease, as someone pointed out earlier, the WHO is largely in hand because it's a monogenetic disorder where from birth, one's high risk can be identified. Alzheimer's disease has had a leg up in its design of these because they've had better biomarkers, as Dr. Dool so nicely defined and gave an example of. Biomarkers are a way to see that process before the clinical manifestations. And there are imaging, brain imaging markers that we covet a little bit in Parkinson's disease that we don't yet have that can be measured before someone develops Alzheimer's disease, where there are changes in the brain, and even spinal fluid and blood tests in the past few years that we're beginning to catch up on. And some of those biomarkers are also defining who's at risk, as I mentioned, imaging and blood tests that I'll come back to for Alzheimer's. This is just, Alzheimer's is a good model. Huntington's is also coming into focus for its ability to stage before traditional diagnosis and frame prevention as a realistic approach. So just in Alzheimer's, when on the far end, this is someone's risk in lifetime. So from, I guess that's birth to late life. If one gets Alzheimer's, cognitive impairment is what happens, after mild cognitive impairment, dementia after mild cognitive impairment. But before that, there's a process going on. There's biomarkers, A beta, amyloid is one of them that happens early enough that if you can characterize it, you can now consider secondary prevention before the disease manifests. And again, not crazy, but even harder, primary prevention. So those keep in mind that those sort of sequences of biomarkers and how informative they can be for developing this kind of approach. So onto the prospects. So this is really what's changed so dramatically over decades now, but with sort of building speed for a few of the elements, particularly on who is at risk for disease. We're all at risk for disease. So it's who's at high risk. And we'll go over some of the things that we've already heard a little bit about today. Biomarkers, in some sense, are the latest piece to surge, but prodromal features, REM sleep behavior disorder, constipation, decreased sense of smell, are other pieces that can precede typical diagnosis. And then the genetics, too, have only come into light in the last couple of decades. And then, so just to highlight that this is something that's been building, and we've been delighted to facilitate the educational part of this for the field at Mass General. A couple of years ago, we started planning for prevention for trial design to know actually how to begin testing, since there have been no prevention trials rigorously done as yet in Parkinson's disease. That was ended up being virtual, as we've all experienced. Although driving up here, I realize it's sort of an overstatement of what we can offer in Boston for the fall foliage. Wasn't this beautiful as it is here? But we did last fall have a galvanizing second get together, and we're planning to continue this. So, and a lot of it was recounting the progress and then beginning that we've made that allows us to think of who might get the disease. And a lot of this has been investment, just like in clinical trials, of the people who are dealing with disease, you all, most upfront, and the contributions that the people for whom this is really happening, their contributions have been organized through a series of cohorts. In a clinical trial, the cohort is people with, in this case, Parkinson's, but people at risk for Parkinson's are now being assembled through great efforts around the world. The Michael J. Fox Foundation's PPMI Parkinson's Progression Marker Initiative is a particularly robust example. But there's also consortiums of patients who have REM sleep behavior disorder, the NAPS Consortium of North America for that, 23andMe, an online gene testing company, is participating in research, so people very young can find out their risk factors. And these folks are being followed, they're contributing information at a minimum, and who goes on to develop Parkinson's disease based on their risk factors is lighting up a path for us here. So here's sort of this continuum schematized from one of our recent conferences from colleagues, Daniela Berg and Carly Tanner, Tanya Samuni, and others of us who have tried to frame this in the few, use this thing. Sorry, 2 screens, 1 cursor, thank you. So sorry, because everybody else is out here. But that's fine. So what I was just going to, in this diagram, the sort of starting diagram of how, in a simple way with these two lines, can view what we know for anybody in the room, but even as clinicians, that the disease, if you look at the orange line, the impairment from the disease doesn't really happen until diagnosis, within a few years of diagnosis, where you can look back and notice something shaking or slowing down or tripping up. But then within a few years, there's a diagnosis, and then unfortunately, until we stop or prevent the disease, it keeps going. And then, so that's the disease. And then there's been this sort of vague understanding that pieced together that the pathology that underlies it is something that started previously. It must have started at some point, but we haven't had a good handle on it until recently. But that classic view, of course, on the motor end, as any introductory class that you've all been through and graduated from, will tell you there's typical motor features that underlie that. And we do know, as mentioned, for over 100 years, the involvement of the structures in the brain. This is the top of the brain stem here from someone who didn't pass away with Parkinson's. You can see that black substance, or that substantia nigra. And then in someone who passed away with the disease, that it's blanched because the brain cells that have the pigment have degenerated. And that's the classical pathological basis for these brain cells. That here's the substantia nigra sort of slip back in place in its anatomical context here, with the cell bodies here projecting into the higher neuron clusters in the brain, where dopamine is released from those brain cells and facilitates normal movement. There's degeneration of those cells. There's loss of dopamine, and that's that scan marker that I mentioned. It takes a picture of those nerve terminals, and you can see when the signal drops off over time, you can try to diagnose disease if with that scan to some extent, or to mark its progression after diagnosis. So that's that. The loss of dopamine neurons here was, and when it's happening, was sort of inferred. But this was pretty much how the disease was thought of, until we started getting a window into the years preceding, opening up the possibility for some of these prevention strategies. So the term that you may have heard used in the last decade or so of prodromal Parkinson's disease has been a way to describe that period, and we've been trying to characterize it. And even within that period, importantly, there are different stages. There's the obvious part just before people notice that they have movement difficulty, that there's maybe subtle movement difficulties that smartphones might or tremor monitors might pick up, something very early. And then prior to that, there's a stage that may have clinical features that is prior to the movement difficulty, but includes things like REM, sleep behavior disorder, or other clinical features. And then there's a sort of what's been a more inferred mythical phase, which is when the disease is happening and there's biomarkers, but we haven't been able to get a handle on them. And that's where so-called preclinical phase, where the disease is going on. And that's this area where we want to try to understand things better, so that we can design trials rationally in this space that we haven't until been able to historically. So just to break it down a little bit further, the premotor phase is one in which there is a biomarker, that scan, that dopamine transporter scan for the dopamine neurons, which has some utility in diagnosis. It has some utility in diagnosis because it's abnormal when people present, and it is for at least a few years prior. So that can be very useful and dynamic in this stage. Also, as one can reasonably infer, if you had a more sensitive way of checking for motor difficulties, even before you might notice it, those sort of mechanical assessments might be valuable measures here. Going into what's happening, and this is just an average, not everybody has REM sleep behavior disorder, for example, preceding their Parkinson's. Only maybe 50% actually end up with a clear RDD, but it's part of a cluster of clinical features that one can measure. I've already alluded to some of them, and that is reflects on something else that is the clinicians historically have been a little slow to learn that the experts in the room could have taught us decades ago, is that it's not just the motor and the dopaminergic features to the disease, but there are the so-called non-motor features, which include the sleep kind of conditions, but as reviewed, everything from the gut, as we heard about earlier, to mood and cognition and the like. This is just to illustrate from a work from Alberto, who I mentioned before, epidemiologically looking at all these features which can happen before the disease and so can be part of a prodromal condition, and just looking at how enriched they are in Parkinson's. So these are sort of now the classical triad of so-called prodromal features: the constipation, hyposmia, and probable, in this case, by questionnaire in an epidemiological cohort, REM sleep behavior disorder. And you can see that having one or particularly combinations steadily increases to over 100-fold more enriched in Parkinson's disease. And if you look at all these even weaker but still associated prodromal features, including excessive daytime sleepiness, depressive symptoms, and the like aches, that it's over 1,000-fold enrichment. So that's cross-sectional in people who have the disease. The real progress has been made by colleagues like Ron Postuma and others who studied REM sleep behavior disorder, for example, amongst these symptoms prior to the development of Parkinson's disease, and found that particularly amongst that particular component of the prodromal syndrome, that there's a very high likelihood, if one has that, it's really not a risk factor, it's a clinical feature. More than half will, over a decade, will go on to develop either Parkinson's disease or another of this family that's linked by the biomarker that Dr. Duell went over, synuclein, or so-called synucleinopathy. So either Parkinson's disease, a little less likely, dementia with Lewy body disease, which is related by synuclein, and then even less likely something called multiple system atrophy. So the vast majority will go on within a decade, which tells you there's a big window. If you identify this population, there's a window to intervene in before. So the Parkinson's horse classically is still hanging out in the stable, and you could work with the beast earlier, just with that time window. But it also tells you that over, and you can calculate it as they've done, at some 6% per year, people will develop, if they have this condition, they will go on at that fairly high rate of developing Parkinson's disease. And other features, not surprisingly, that one might have can increase or decrease the rate of converting to Parkinson's or one of those conditions. So that brings us to this sort of the earliest point, and what has been in just really recent weeks come to a head, even though there's been work going on in this area, again, coming back to biomarkers. So before there's any clinical features, prodromal or motor Parkinsonian, there's evidence that the disease is in process, and that there are things you can measure. There's lots of candidates, but this alpha-synuclein, which has been implicated in the genetics of the disease as well, has been the most informative. The hope was actually like the Alzheimer's field, where these other proteins have been lit up by brain scans and tracked, that we would find for alpha-synuclein a brain scan that could identify people before the disease and during the disease, but that hasn't happened. It's turned out that there's been better ways to measure the pathological nature of alpha-synuclein in fluids. Most of the recent data, and I'll show you a little bit now that's just been in the news, was from spinal fluid, but there's pretty good evidence that even more peripherally, perhaps related to the point that Dr. Duell was highlighting, that outside of the nervous system altogether, there's synuclein pathology. It might be something that can be measured in blood. There's studies that have found some evidence in this COVID era, where we're all a little easier to put things up our noses to swab for synuclein, or even saliva. But for right now, the best evidence has been from actually skin biopsies, and particularly from spinal fluid. And this is a study that was also just in the news because it's while it again represents a lot of work that's going on from all over the world, that Michael J. Fox Foundation supported juggernaut of an initiative, the PPMI, Parkinson's Marker Initiative has been most systematic in following people for the longest time, and now has run these synuclein seeding assays, they're called, on all the people that have entered the study, and the observations from that have been confirming the power of this as a marker of the disease. And this just shows, sort of in classic terms, the specificity and the sensitivity for this synuclein aggregation assay. The same thing that Ben Franklin was maybe worried about in his prescient way. That these aggregates, their ability to aggregate that's tested in this assay is very specific. So if you looked at the many people who were healthy controls that had joined that cohort, 96% don't have this signal. If you look at the people who have Parkinson's, all of the people with Parkinson's in the study, you can address the sensitivity and seeing that almost 90% had a positive signal. But it's actually better if you look within all the people with Parkinson's in this cohort at subsets who had particular features. So again, hyposmia, decreased sense of smell, almost 100%. If you had hyposmia and had been diagnosed with Parkinson's traditionally, you have this alpha-synuclein signal. If you just take just people with non-genetic Parkinson's, so it's over 90%, 93%. And then we're not really talking so much about the genetics, but there are clearly clues as well. And it's curious to some extent. There's the two mutation variants, the genetic variants that are most common and relevant to these gene-targeted trials that are going on. One's GBA and the other's LRRK2, as were mentioned. If one carries the genetic risk factor from GBA, this synuclein assay is positive, again, almost 100%. But there's a curious phenomenon going on with a different kind of genetic form of Parkinson's linked to LRRK2, where it's much less, still the majority. But so there's things to sort out, and it's leading to some some controversy, but they're great controversies to have. Like, do you call there's, as I'll briefly allude with this news that we can now better define Parkinson's by synuclein, as some people are proposing from the recent findings. Does that mean if someone has what's typically in the clinic been called Parkinson's disease, but they don't have a positive test, they don't have Parkinson's anymore? That's something to consider, since for the vast majority, it actually there would be a positive test. So this is just a little bit of the data that came out last week, and I think, again, because it came out from the Fox Foundation, there's such an investment in trying to develop biomarkers, and this biomarker is being substantiated so nicely that it's considered a milestone. And as I heard here, as it's down in Boston, the phones are ringing because Mr. Fox received a special flight of scientists and staff to present him with the results of this breakthrough. So that was kind of made the news, but there's some substance beneath it for this, even though it's just a step towards actually the trials, prevention or otherwise, that are now increasingly possible with this tool. So this here is this assay, the seeding assay. You can have a positive or negative result. This is just a part of the paper that just looked at those who had been diagnosed with typical Parkinson's disease. And then you can see that most everybody has a blue spot here, because in this scatter, most people, as I mentioned, have a positive test if they were diagnosed with Parkinson's. But this also puts the diagnosis into the context of two other markers. This is that DAT scan here on this side here, and this lower means lower signal of dopamine neurons left in the brain. And there's this line here that, not surprisingly, everybody's pretty much underneath, because by definition, they got into the study because they had a low value here. And on this scale is a smell test result. And the vast majority are here, where they're all blue essentially. But then there are folks who don't have smell deficit, have typical Parkinson's, and some of them do have a positive assay and some don't. So there's some features that are and the genetics along those lines are still to be figured out. But they're also, not only in seeing this as beyond, okay, so now we have a test like that scan that that movement disorders doctors can ignore because we feel we're just as good as any test. Beyond that, there's a suggestion that there's benefit here looking earlier. So here are REM sleep behavior disorder patients in this study. It's a smaller subset, but you can see now there are some people who don't have a DAT, or dopamine deficit here, but essentially everybody who doesn't have normal smell is positive for this test. So even though RVD happens years earlier before diagnosis, already most of the people who have RVD have a positive synuclein scan, telling us that there's sort of a sequence going on here. And this is from a paper that's just in press from Lana Shaheen and Tanya Samuni and colleagues that shows a picture of kind of what I showed you for Alzheimer's disease. If this, the colors are changing, but the idea is after diagnosis clinically, that's when things are most manifest. The DAT scan is also increasingly shows abnormality. But years before, there's a process going on where this blood test, spinal fluid test so far, but a fluid test is showing that the disease there's evidence for the disease, particularly if you consider it a synucleinopathy. So again, that's that staging. Just to delve just a little bit deeper onto the education that we're getting from Alzheimer's and Huntington's, it's kind of redefined Alzheimer's over decades, for the most part, that it's now defined Alzheimer's by these biomarkers. The letters are different. It's amyloid and tau, but it's akin to synuclein in terms of a marker before people develop dementia or even mild cognitive impairment, changes that happen. And to enroll in a prevention study for Alzheimer's, you need to essentially have these markers positive, and then one can try to prevent the cognitive changes. And it's led to a whole naming system, also some challenges. This is Alzheimer's here, where we're defining the disease now and setting up stages based on these biomarkers and the sequence in which they appear can be very helpful. But it also means that there's some people who were thought to, who don't have those markers, who have dementia from some other source, and so that's led to this new biomarker based definition of the disease. It's analogous to something going on in Huntington's disease, and there's proposals now to have it happen in Parkinson's disease. By having these discrete stages, you can, even if not everybody reads the textbook exactly, but if the pattern is there that's strong enough that tells you that this is likely the disease in its earlier stages, previously not visible to the naked eye, then you can start designing interventions to try to get studies that will take advantage of that. And it's important, particularly for drug makers, because the FDA in this country plays a key role, and they're recognizing these stages and allowing you to design a trial in the context of those kinds of stages can be very leverage providing for those who want to invest in that. Actually, Billy Dunn, who just left the FDA and Neurology division, has been a voice and at our conference last fall highlighted this staging and helped galvanize some of the enthusiasm. So I just showing you how rapidly this is changing. In addition to that study that was just published last week in the news, there's two partially published staging proposals, actually two different camps. All colleagues, we were talking a little earlier how nice it is somehow, particularly in the Parkinson's field, that there's such collegiality and everyone's working towards the same common mission, but people have different views. And I was at a conference last week where the authors of these two different staging proposals, basically based on the data I was just showing you and data like that, are saying there's a basis now to redefine Parkinson's in terms of the biology and then to propose different stages. Because that will only make it more likely not only to do prevention trials, haven't quite started yet, but also to actually to focus on the biology, even in manifest Parkinson's disease. So that's the upshot. There's a new thinking afoot, and it's based on just the kind of data I showed you. Nevertheless, if you're going to restage the disease as it happening before what we have typically called Parkinson's disease, you have to deal with some challenges. And it's interesting in looking at these two different proposals as they're playing out. some of the best thinkers in our field have come up with very common elements, but also some differences. So, for example, with a synuclein assay, if you have a positive assay, positive result, some would propose that you have Parkinson's disease. That might be millions of people more who, by that definition, could benefit from a treatment that prevents it, which might be great. But also, you have to be pretty sure before the saliva version comes out in CVS and people start, coming to their doctors with a new diagnosis. So we have to be careful about the ethics as well as the rationale for redefining it as something before the way we've traditionally defined it. Now, on the flip side, like I said, if you're going to define it by synuclein, there are some people who have what seems to be Parkinson's. This is a relatively small proportion, but who don't have a positive result. So I think we'll get past all that because it's for a good cause to try to better understand what's wrong with the disease so we can move earlier. So that reflects a lot of the excitement about why we're rethinking about what the disease is at earlier stages or who's at risk. Even the terminology of prodromal, I've heard echoed a few in the last couple of weeks. We have to stop using the term prodromal, which we only just started using, so it's a bit of a challenge. And who's at risk for the disease? Well, if they already have the disease, they're not at risk. But as long as we're on the same terms biologically, I think we're making progress. So, Joe, the pieces to pull together in actually designing the trials, there's other things you have to figure out. If it's prevention, you need to know, well, you're either going to measure traditional Parkinson's disease and do a study and measure the development of the disease. Coming into a neurologist, doctors often saying you have Parkinson's disease. You start with people who don't have it. Your main outcome can be so-called phenoconversion, turning into what's called Parkinson's. But particularly if you look earlier in the process, that can be years, decades before. So very few people are interested in running a 20-year study. So there are other things, at least in early studies, that may make more sense to measure. And that's what is informed by, again, thinking of the disease and the knowledge that we're gaining about the sequence in which prior to diagnosis, things are changing. So in terms of how to measure progression, it's simplest in the few years just before traditional diagnosis, when, as any of you might think back, there were things going on that were changing that led you to your clinician and a diagnosis. So, and as I reviewed, you can look at DAT scans as a biomarker. You can look at fine quantitative motor testing, and those could be the appropriate things to measure if you're taking a group of people who are very close to a traditional diagnosis. But if you move earlier, then it may be too many years to just wait for even the movement features. And actually here, we're still trying to figure out what to measure, whether these biomarkers like synuclein, which is so prominent for its indicating the disease, it's actually, for the most part now, a plus or minus test. So more levels of synuclein is not something that we have worked out yet. And it's even more challenging earlier. But as you can see, the landscape is moving with our understanding. And for the first time, we can begin to think of how to design these studies sort of as an afterthought. Well, if you figure out how to do the study, then anybody can test whatever they think is good. But since we're really on the verge of conducting these studies, it's reasonable to start thinking of what to test first. And I have a couple examples. Looks like there's time still for to go through just a couple of how we begin to think about it. Because you might say, well, just go back to your list that you had and go to the graveyard and start digging and take some of those things that maybe you tried too late. It's always, not that I say this out of experience, always be careful digging in a graveyard. But there are some things that are more compelling. Actually, in the Alzheimer's field, that activity with some public outcry has gone on for a while, where a study, the beta amyloid hypothesis, has been through dozens of major trials, and some have lamented, well, again, why are you going back to do the same things? Some have been dug up. I have to drop that, but some have been returned to do earlier studies, and that's rational. Some have just been done repeatedly. But so going back to those that have already been done, there may be a rationale for doing that. But there are other considerations too that may be specific to prevention here. And that in terms of what to actually pursue. So there's another issue here, because now you're moving into giving people experimental therapies that, like any time a trial is done appropriately, is always a thoughtful consideration of the risks and the benefits of exposing someone to something that might help them, but you tolerate a certain amount of risk. You might tolerate something with higher risk if you have a disease and it's going to give you more trouble down the road, like Parkinson's. But if you have the disease and you only have a risk of if you have a risk of disease, or you have early features that might of themselves, even RBD might not be considered a disease, more of a disorder. You might want gentler things to try. So the general idea is that the more advanced prodromal stage would be where new drugs would be tried. We've tried to make the case, as others, that early on, it might be good to try things that are repurposed or generally considered safe, and think of candidates that are rational, that are you can consider on the spectrum of risk that may be more of a prominent consideration for prevention trials. So we had reviewed these. Things are changing, but the general principle is on this list. I won't go through all of the candidates, but they are obviously on the far end, where there's all these interventions, including antibodies and gene therapies that get infused into the brain, that you probably won't try on someone who has a positive test in CVS, but are appropriate in manifest Parkinson's disease. Some are drugs that are probably safer, but these, I think, for general, you might want to see some signal in manifest Parkinson's, or have a strong rationale before moving into prevention studies. But there are other things that have been linked, and some to particular prodromal features, like cough syrup. Thank you, Q. That's widely available and has some positive signal for the GBA, and also REM sleep behavior disorder being associated with GBA, where there might be a rationale for that as an early test. Ibuprofen has been linked to in people at risk for LRRK2 Parkinson's disease, where lower exposures are linked to actually getting Parkinson's if you have that risk factor. Caffeine is an example that I'll actually go through here, just that's come from our work and is relatively safe, and is an example of something that one can consider on sort of this list of associations that are that I mentioned earlier, are exposures linked to a reduced risk of getting the disease. So I'm just at this stage, I'm just going to highlight some of how caffeine has arisen as a variable, as a inverse risk factor in Parkinson's disease, without showing you any of the data, but it comes from epidemiological studies, primarily in people actually not who have Parkinson's disease. In this case, unlike the urate story, where caffeine isn't as strongly linked to getting worse or not. But if in healthy populations, younger populations, caffeine is linked in coffee, but not decaf coffee, and other sources of caffeine, all been linked to a reduced risk of developing the disease, which may be more relevant, that kind of epidemiology, to prevention, because of course the association is relevant for prevention. But like as I mentioned earlier, association studies, epidemiological studies, inherently can't address causality. So just because caffeine use is linked to not getting disease doesn't mean it's the caffeine that prevented it. It could be something different about a person who doesn't like caffeine, that increases their propensity to losing dopamine brain cells. Well, this is ever so briefly at this point just an example of the idea that at least you can take some of these questions into the lab to look at the biological plausibility. Could caffeine even protect dopamine brain cells? And this is work that we did decades ago now, with a toxin here and measuring brain dopamine. This is in mice, not in people. And you can give the toxin MPTP, and you can show that after a week, the mice that got exposed to it lose almost, the vast majority of their dopamine. You can also look at again, that same brain signal area, the striatum there, and see with MPTP that almost all the nerve terminals are gone. But if you pre-treat with standard doses of caffeine from a human exposure, you can prevent that in a mouse. You can do it in other toxin models. You can do it with synuclein. It's actually fairly robust. Again, it doesn't address the whether that's what's happening in humans, because mice are not people. But even further mechanistically, caffeine has most of its effects on the human brain through, as it turns out, there's been a lot of things linked. But in the exposure range, this is a dose response curve, higher concentrations of caffeine. You get enough, you'll go to the emergency room with toxicity. But a cup of coffee and the exposures you get within that range, short of the emergency room, are mostly hitting in the brain these so-called adenosine receptors, which I'm only belaboring here. So this is the typical. So what happens when you have caffeine? You block these receptors. So could that be protective? And that in animal models has been also you block the receptors with more specific drugs than caffeine. Just the adenosine A1 receptors, not the A2A receptors, not the A1 receptors. You get protection. The caffeine that protects the mice, if you give it to an animal that is genetically engineered not to have these receptors, you'll lose the protection. So there was a lot of sort of biology implicating plausibility of protection. And with the risk factors of the genetics, we teamed up with colleagues at a company called Denali that has a biomarker system of their own to pursue something called metabolomics, where you can take serum of patients who enter these studies, and we looked at their blood of people who had Parkinson's and those who didn't, and those who had this risk factor, in this case, this LRRK2 variant, and those who didn't, in this metabolomic study with Sarah Huntford Rodriguez and her colleagues at Denali and our group at Mass General. And so we measured hundreds of plasma samples with and without from people with and without Parkinson's and with and without this LRRK2 pathogenic variant. So this is my last biomarker slide here, just to show you that in people, and I'll just point out this is a volcano plot because it looks like a volcano, and each dot is one of the molecules measured in plasma from people with Parkinson's or without. If it's to the left of the line, that means that the value of the analyte that was measured in plasma was lower in people with Parkinson's than controls, and to the right, the opposite. And the biggest hits, to our surprise, actually, we just did this a few years ago. It turned out it was caffeine and metabolites of and markers of caffeine that were the biggest hits. Urate, just to put it in context, was also lower in people with Parkinson's, but it was a much weaker signal. And then amongst people who had this LRRK2 pathogenic variant, it was an even stronger association. So the levels were even lower in the blood of people with Parkinson's compared to controls if they have this genetic variant. And I won't belabor this here because I want to leave time for questions here, but this was actually a follow-up. This is the PPMI study where, based on those results, we got 1,000 blood samples from people with or without Parkinson's disease and with or without a genetic variant, either the LRRK2 variant, or in this case, we expanded to look at people with and without the GBA variant. And we measured hundreds of analytes, again, with our colleagues, and replicated quite robustly in LRRK2, and in fact, all people with Parkinson's, lower levels of caffeine and its analyte paraxanthine here in blood. It's a little hard to see because it's lower in people amongst the orange folks here. It's not their color, it's just the labeling, who have the LRRK2 variant. If they had Parkinson's disease, their blood level of paraxanthine, I'm sorry, I'm pointing blood level of paraxanthine was lower with Parkinson's than if they were controls. And that was the same with GBA variant carriers as well as people without the variants. It's a signal that was quite robust, even if modest, and consistent with there being a difference in Parkinson's patients. Interestingly, GBA markers for this genetic form of Parkinson's, where you can see very great differences in people who are blue here, who carry, whether they have Parkinson's or not, minus or plus. You can see there's much lower levels of the actual enzyme activity or of a precursor of a lipid in the blood, defining the biochemistry of this risk factor. But there was no difference in their levels, if they had the disease or not. So bringing up some questions about this, targeting this for people who have this variant, but just pointing back to the solidness of the associations with caffeine and its metabolites with the disease, lower levels, whether or not it's causing or not. It's clearly a robust phenomenon. This is the last slide here with any data, which is just to show that we looked at people with a marker of this adenosine receptor that caffeine works on, that you can light up by doing a brain scan. And you can see in two people here, these are two women who have this LRRK2 variant. They don't have Parkinson's disease. And you can see that their caffeine receptors are strong. These were people who don't consume caffeine. And then we gave them caffeine and then ran their scans again. And for essentially the rest of the day, they lost the caffeine bound to their adenosine. So it's not actually earth-shattering, but it just tells you that this target for caffeine is present in the brains of people who are at risk for the disease, and just allows us to propose this. And I'm not going to show much detail except to say that the first prevention trial is actually that's being planned, and where the actual intervention is publicly disclosed is actually exercise for a lot of convergent reasons, even if it doesn't speak directly to synuclein or LRRK2. And colleagues in the Netherlands, based on a lot of convergent data that I'll just click through at this point, epidemiology, animal models, mechanisms, phase 2 trial data supporting exercise making a biological difference and clinical benefit, is leading to a study called Slow Speed that's going to be recruiting folks. Bas Boom is the lead in the Netherlands, that's going to be recruiting people who either have these genetic variants or have prodromal features like RBD and other features, and they will be enrolled and followed through one of these early designs. So the future is here, actually, for trying to prevent the disease. The last point, just on exercise, an easy take home if you haven't heard this before. Despite the data that aren't class 1 clinical trial evidence yet, there's good evidence enough to walk along Lake Champlain here and enjoy a stroll, because it probably is very good for you and your mind and your brain and Parkinson's. So that's what I've tried to cover here. Again, this is sort of a community effort, particularly people who have not only Parkinson's, but have the risk factors, are important to have in this planning stages. We have our meeting planned for next year to continue the series in May, where we hope to be able to facilitate the conversation. I just wanted to close in memory and thanks to Mr. Gupta, and how his legacy is highlighting some of this hopefulness that continues for us. So thank you all for your attention as well. And
thank you indeed for such a comprehensive review and latest and greatest state-of-the-art information. It was really awesome to listen to you. We do have some time for questions. I think 10 minutes, give or take. So we'll go person by one person.
So my first question, I have 2 questions. Closer? Okay, I just didn't want to eat it. My first question is, when a person is diagnosed with a REM sleep disorder, the suspicion is it's related to a medication, it's not idiopathic. Do you still investigate for Parkinson's at that point, or do you wait to see if something else could do that? So that's my first question. My second question, sort of along that, if there is a history of Parkinson's in your family, how far out do you go with the genetic piece, generation-wise or relative-wise?
great, it's 2 very thoughtful questions. Yeah, and both the answer to probably both is it's relative. the REM sleep behavior disorder diagnosis and the utility, there's different levels of diagnosis. Rigorous studies use a criteria and a polysomnogram test where you come to the hospital, you get your sleep tested, and if it has the features, and if it doesn't have other confounds like medication induction, that's a more rigorous definition. But most thoughtful definitions will consider other features. In terms of genetics, it's a little bit of a tricky discussion, because we consider Huntington's disease a genetic disorder. Parkinson's, where for the most part, it doesn't run strong in families, but the genes are terrific clues. And in a subset, it does run in families. If it runs in your nuclear family, that is your kids, that's more uncommon. Your siblings or your parents, that's a greater risk than if it's in your aunts and your uncles. And of course, genetic testing can at least for a subset of the genetic factors, can get past how far they are from you, just to find out whether you have that particular predisposing factor.
One of the charts on risk factors, it mentioned melanoma, but there was never any clarification of that. Is there a clarification?
So good eye. And sorry that the slides were a little clustered in showing the risk factors and putting in context things like the caffeine in the urate. Smoking, someone might also highlight here, which is its own clue that's been pursued by Dr. Boyd and others, are examples of the many clues. Melanoma is one. So there's a personal history where melanoma is people who have melanoma are more likely to get Parkinson's. People who have Parkinson's are more likely to get melanoma. If nothing else, it's a good reason with Parkinson's to be vigilant about things that might pop up on your skin. That's at one level. And the other, it's a clue. And there are laboratories where melanoma mice are checked for their Parkinson's. Red hair is also modestly linked to Parkinson's disease through a melanoma linked gene. So it's leading to a lot of those kinds of observations are more interesting, slightly clinically relevant, but more clues that are being pursued.
A question on the alpha-synuclein assay. This alpha-synuclein is the main brain protein involved. But does alpha-synuclein occur in the rest of the nervous system, or is it strictly a brain protein?
Yeah, that's a great question. It not only exists this brain disease focused biomarker, not only exists outside of the substantia nigra, but it's actually very heavily expressed outside the brain in blood cells, for example. So, and the question was thoughtfully, does this synuclein marker for the disease only occur in the brain in the area of the disease, or does it occur elsewhere in the brain? And I'm just extending it to point out that it occurs quite widely. So it's consistent too with this being relevant to the disease being a systemic disease in the gut, for example, in the skin. Actually, some of the best biomarker data are not only from the spinal fluid, but also from skin. So yes, it is a widely expressed protein. Why synucleinopathy is a brain condition? There must be some special susceptibility to brain cells.
For those that are parents, not a single part, and they're oftentimes but the symposium comes out or where do you go to find out what things really Parkinson's symptoms are being told.
You want?
I was going to say clinicaltrials.gov. So the government, the National Institute of Health, they have a website called clinicaltrials.gov, where you can enter any disease condition and you will see all the trials into your zip code, down level or state or international, and you can subscribe to updates, I believe. So that's one.
Yeah, and the Michael J. Fox Foundation has a particularly good foxtrialfinder.org, where you can map your zip code and your. This is actually mostly though not for children or family members, because the field hasn't shifted that much to prevention. that there are trials yet. I mentioned the one exercise trial, but there is information there about trials. The Fox Foundation, just in terms of the prevention thing, I think actually is doing a screening for not on the genetics, but anybody who has decreased sense of smell can go online and they will send you a sniff kit, and you can, and then you'll send it back. And if this would be more for, I think you have to be 60 years old for that. So the future isn't quite here yet for children, but it is a tricky thing. So if you have Parkinson's, one thing you can do if you're interested, after a thoughtful discussion, is one can get one's genetics checked online, 23andMe, for example, if one wants to understand their risk. But for kids, while it might be that someday it'll be important to know that. Until there are actually trials that are recruiting, I'm not sure actually how useful it is to get one's young children genetically tested. Well, forgive my assumption.
So two of the things that I could understand was dairy and REM sleep. Could you put a little meat on the bones about how those things can be risk factors?
Okay, well, the dairy, which probably was out on one of the slides too. Yeah, so that relates to nutrition and the like. We actually discussed at the break that while protein, as you asked about, hasn't been linked, epidemiological studies have found a link for dairy, and these are actually prospective studies. So not one where there's a concern for bias, because people filled out in large populations, in this case nurses and doctors, what they ate and what they did in extensive forms, and then it wasn't they recalled it; they were just followed for decades. And people who developed Parkinson's, compared to those who didn't, had their data accessible as to who ate more of what. And so, yes, dairy has been fairly consistently linked. Again, it's not the cause of the disease, but there's an increased risk about people who consume more dairy. It's a bit of a challenge, but it's definitely a clue. Could it be that just the people who are lactose intolerant or have some confounding reason for not liking dairy also have an increased risk? Could it be that there's something in the in milk, pesticides, for example? So for a while, dairy link was pointed to as, well, that's consistent with people drinking milk from cows that gets pesticides from the farmland. So see, that supports the toxin model. Even the urate story was tied up in this, because if you drink dairy, it lowers your urate levels. Actually, well known. So it's frankly, it's not enough to put the drink milk advertising campaign at threat, or to change one's dietary habits. But it is a clue, and it's harder. Some of the nutritional clues are harder to pursue, because milk, even if you pursue the hypothesis that it's milk's got a lot of things in it. So it's a clue, but I wouldn't necessarily change your dietary habits over it.
I just want to say that given the different ways all it's amazing. Anything. It takes incredible minds to go through all this and within your own group with others being everywhere else about. So it's available. Thank you.
Thank you, Ms. Pankowski.
Very kind of you to say. I think if there are no more questions, I just want to make a comment to that, follow up to that. So alpha-synuclein is in CSF being proposed as a test, but it's also actually, there's two companies who have developed biopsy of skin, sort of nerve tissue, where you can bind the protein, and it is now approved as a formal test for Parkinson's, where you don't have to go in the brain. And I have a question related to that. Do you think we're going to get a lot of call? When can I get this test ordered for CSF alpha-synuclein seeding assay? Where is that in terms of the approval, if you have any inside knowledge of that?
I don't have inside knowledge, but for better or worse, I think the deluge of phone calls for having spinal taps is going to be a small flood because of people's apprehensions. I think it'll be a bigger issue if it's a swab or the like. And so, I think it's a tricky thing, but we can all in the room understand it, that these are advances but there are advances on the way to what those phone calls will best be for, which is when they lead us to design a better trial, to actually demonstrate something that prevents or slows down the disease, so that the call can be responded to with a prescription or something.
I think you're all good here. Well, thank you very much for coming in person, and all the people on Zoom and we can't see. Thank you all for joining. And I think we'll close at this point. So you guys have a great afternoon and have a great weekend.
Thank you.